We are very fortunate to have a keynote speaker amongst us, Dr. Nihal Hassan. She is the professor of ophthalmology from Cairo University, and she'll be speaking on ultrasonography in pediatric ophthalmology.
Mrs. Chairman, dear colleagues, good afternoon, everybody. First, I would like to thank the scientific committee for this kind invitation. It's always a great pleasure for me to join in all India meetings every year, and to my great pleasure. As we all know, the pediatric age group, these are challenging cases to reach to the proper diagnosis, especially posterior retinal and optic nerve assessment and visual rehabilitation and visual assessment for further visual rehabilitation, as in the previous very nice, excellent talks. The aim of my presentation is to illustrate some of the posterior ocular abnormalities and pathology that we meet in children, especially in media opacity, and for proper assessment of the posterior pole. I used the 10 megahertz probe longitudinal and transverse scans were done not only to assess and measure the axial length of the globe, which is important to know the growth and the development of the globe in infancy and newly born, but to detect many of the congenital anomalies and ocular pathology, which are very common in the first 1 year of in the pediatric age group. As we all know, the persistence of the hyaloid canal and the persistent permixture papilla, whether to see it just a very small prepapillary fibrosis, pyramidal in shape projecting in the vitreal cavity, or to be in the midvitreal cavity with scattered vitreal opacities, or extending even to the posterior pole of the crystalline lens with dense opacification. And this is very important, especially in the presence of congenital cataract, posterior polar cataract, if there is patency of this hyaloid artery and hyaloid canal, or it might present even with, as this example, with vitreous hemorrhage, and should be further assessed. A small globe with the dense opacification, pyramidal in shape, which the persistent hyperplastic primary vitreous, which is very common, especially in unilateral leukocoria, and to be differentiated from ROP, which is very important to be and very common in bilateral condition, usually an eye preceding the other, with fractional retinal detachment and funnel shaping, with retrorental dense fibrosis in the vitreal cavity. And to go for a large globe with a long axial length. To first, we very common to see the optic nerve with the cupping, the classic cupping in ophthalmos, and usually is very obvious, and to differentiate it with the irregular excavation of the optic nerve head in optic nerve disc hypoplasia and coloboma. Or it is associated with excavation of the choroid below, usually in the infranasal, according to the embryological fissure of the embryological development of the globe, associating a choroidal coloboma as well, with or without the posterior hyaloid would be persistent. And the irregularity, the severe extensive irregularity in the posterior pole with extensive choroidal and optic nerve disc coloboma, to be differentiated from a large myopic anisometropic globe with the smooth posterior staphyloma of the globe. And this is another case with optic nerve head coloboma with smooth colobomatous optic nerve head, but associated with inferior detachment, and a case of complicated cataract associating this case. Another example, a microphthalmic globe with irregularity at the posterior part of the globe at the optic nerve head shadow, with even discontinuity of the optic nerve head, hypoplasia, and optic nerve head coloboma. Nanophthalmic eye, which is less than 15 millimeter, we have many of these cases presenting with choroidal coloboma, and it might be even an orbital cyst communicated or not communicated to the optic nerve head, behind in the retrobulbar space. And this is another case of the nanophthalmos. We have a multiple abnormality in an eye, the right eye, showing persistence of the posterior of the primary hypoplastic primary vitreous with irregularity in the optic nerve head, and the left eye showing an orbital cyst associating the optic nerve hypoplasia. And even in cryptophthalmos, but sorry, I lost the sonar for this case, which was important, that I used the sonar to assess if the globe is can be differentiated globe or not, to do anything for that poor child. In cases with traumatic cataract with the dense media opacity, I can differentiate. Of course, it's very important for the surgeon to see if there is intraocular foreign body in cases of penetrating injuries associating vitreous hemorrhage, to be differentiated from leukocoria, a case of the different causes of leukocoria, especially retinoblastoma with the pathognomonic calcification and the irregular homogeneity of the retinal mass. And if it's associating a dense vitreal condensation of intravitreal dispersion of this advanced retinoblastoma. In cases of complicated cataract with uveitis, and this child with Harada, Vogt-Kanagi-Harada syndrome, and to see what's as the assessment of the posterior hyaloid with partial posterior vitreal attachment to the irregular elevated optic nerve head due to previous attacks of posterior uveitis with neuroretinitis, as well as in clear, even in clear media, where I can photograph the fundus of the child, but we need the sonar to give two-dimensional scanning of these cases. As in that case, he was referred to me for irregularity in the optic nerve head, and the very obvious choroidal, isolated choroidal columboba behind. The sonar showed irregular elevation in the optic nerve head with just its remnant of the posterior permixer papilla and the posterior hyaloid attachment rudimentary part of it, and with a very shallow choroidal, inferior choroidal coloboma. This case with optic nerve disc swelling, it's very important for the child to do the first thing, ultrasonography, to exclude the possibility of optic disc drusen, which is very common, and we'll go for a dilemma of neurological assessment of that child, and simply it's optic nerve head drusen. But it's not simple, because as you all know that optic disc drusen should go for neurological and endocrinological assessment, because there are many abnormalities in these children regarding the corpus callosum. And to do, if he's a child that can be cooperative on the visual field, we should do him visual field, because this drusen will enlarge by time and will compress the nerve fiber layer and will lead to visual deficit for this child, but at least to know that he's going for an optic disc drusen. It might be as that, which high echogenicity, or it might be even embedded inside the optic nerve head, as in this condition, and not that much elevated disc. Even if here it was only for sonar, then for my interest in this sonar is only elevated disc, which I can't go for optic disc edema, but as well there is nothing significant that I can correlate clinically, and it's a clear media, but the child was not cooperative with the pediatrician or with the ophthalmic pediatrician to examine. I took simple photography with a narrow pupil that I can use on my fundus camera, and it's a dense myelinated nerve fiber layer, which gave a grayish reflex that it was disturbing the clinician. So ultrasound for ocular scanning is very essential, complementary for the diagnosis of the clinical examination case, especially for to detect the ocular pathology, especially if the child is very young, uncooperative child, which is more convenient for the child and more safe to try to do ultrasonography instead of examination under anesthesia in these cases, especially if narrow pupil, and it's two-dimensional to detect any underlying lesion, detachment, or intraocular masses, and reproducible for the follow-up of that child. Thank you very much for your attention.
Thank you, ma'am, for an excellent presentation. Any questions to ma'am, please? So another diagnostic. So has ma'am finished the talk on sonar in pediatric ophthalmology? Yes, it was very helpful. Thank you. Um, we go to next prognostication or the next diagnostic. Oh, you have a question? Sorry.
In case of a Goldhar syndrome, have you experienced optic nerve drusen? A Goldhar syndrome is a condition which is characterized by congenital limbal dermite with preauricular skin tag and appendage. In literature, I have seen about 4 or 5 cases of Goldhar syndrome, which are basically normal from visual and optic nerve point of view. Because 80 to 85% cases are normal. It's only in 10 to 50% cases that you get additional congenital defects like Ayer's palate, defects in the kidney, congenital heart, defects in the dental anomalies. They have impairment of the memory. And just because I think you are a pediatric ophthalmologist, I'm also a pediatric ophthalmologist. Do you have experience any case of an optic nerve drusen in Goldenhar syndrome?
I didn't meet.
Sorry?
In my experience, I didn't meet a golden hair with optic nerve head drusen.
What I
Golden
want to
hair.
say is that I also have not seen, but in Indian Journal of Ophthalmology, 1968, Mittal et al. Reported 3 cases of optic nerve drusen with Goldhar syndrome. Goldhar syndrome, you have about 17 families which are in Greece. There are Goldhar syndrome support groups. Children born in Middle East during Gulf War and military hospitals have a high incidence of Goldhar syndrome. It's Mittal et al. If you see in Journal of Ophthalmology, in 1968, it reported 3 cases of optic drusen associated with Goldhar syndrome.
It's
Thank
very
you.
nice. Thank you very
Thank
much
you,
for
sir, very
the.
much. Yes, we should. What I think what he's saying is that we need to look carefully when we see a golden hour syndrome.
Yes.
Maybe we should also investigate for